Hello, today's web lecture is on trauma training and simulators. Here's the problem. How do we prepare individual practitioners to become trauma teams? And how do we prepare medical personnel from a peaceful country to prepare for a war environment or to deal with multiply injured patients? Trauma is an ongoing event that occurs every day in our country. We're also having members of our medical community working within the armed forces having to deal with severely injured patients working in places like Iraq and Afghanistan. Advanced trauma life support, a course that's been present for over 25 years, has been highly successful. It has revolutionized trauma education and trauma care. It's used in over 180 countries. It's an introductory course for individual physicians and physician extenders in learning how to deal with the multiply trauma injured patient. However, the course does not discuss team dynamics, and the dynamics of a trauma team are beyond the purview of ATLS. Trauma team training, however, has been adopted particularly by the military. In places like the Joint Trauma Training Centers, which were first started in Houston, Texas, embedded military training teams within a civilian facilities use their large urban level 1 trauma center as a place to train military trauma teams who are being deployed overseas. The U.S. Army has one such center at the Ryder Trauma Center in Miami. The U.S. Navy has theirs at LA County USC Medical Center. The U.S. Air Force uses the R.A. Cowley Shock Trauma Institute in Baltimore, and the Canadian Forces has theirs at Vancouver General Hospital. These trauma training centers are used because we know that trauma has evolved. We feel that our military personnel deserve the best, and that the standards have changed since the Vietnam era. There's no opportunity to have a learning curve when you go to a place like Iraq or Afghanistan. You have to be ready to go on arrival. We also know that the public, the media, and soldiers are acutely interested but will not tolerate mediocrity. It's no time to look like the Keystone Cops when these patients start arriving. So why do we do this? We need to have team training. Trauma is not an individual sport. It's a team activity. It requires a strong team, and the team is only as good as its weakest link. Simulators, such as procedure simulators, have been around and been used in ATLS for teaching individual skills. Skills such as intubation, chest tube insertion, diagnostic peritoneal lavage, central line insertion, and surgical airway can be taught on these procedure simulators. Human patient simulators are a newer innovation. Simulators such as those made by the Medi Corporation include the Human Patient Simulator, which provides a simulator for ICU and anesthesia care, the ECS simulator, which is used in trauma care and emergency care, and the iStand simulator, which is a wireless version of the ECS with some new features. It's a procedures mannequin and also contains a computer algorithm which can simulate such things as heart rate. The mannequin also simulates respirations and can provide such stimuli to the team such as bleeding, tearing, voice, and movement, which can allow the team to interact with the simulator as they manage the trauma. There are some cautions about adopting a simulation program for trauma training. First is the investment required. The simulators themselves run from about $65,000 to $250,000 depending on the model and numbers required. A single iStand, however, can be attained for about $65,000. However, it does require a dedicated operator, dedicated faculty willing to spend the time to learn the device and teach with it. You'll also have to deal with the popularity. Once people have a chance to work with a simulator in a team training environment, they will enjoy the education, and the demand will be very large. It does take time, and this can make for many requests for training that do have to be met to avoid disappointment. Also, the standards of performance have frequently not been set in many areas for use of the simulator. While it is possible to document improvement in performance, what certain standards have frequently not been set. For instance, how long a particular procedure should take in performing trauma resuscitation. We performed a study at Vancouver General Hospital To use the human patient simulator training combined with the civilian academic educational environment, including didactic sessions and clinical rotations, to develop multidisciplinary team skills and improve a trauma team's performance. We used a course we call the Intensive Trauma Team Training Course, which was a 2-week course immediately before deployment of Canadian Forces personnel to a surgical unit in Afghanistan. The course had a size of 12 to 24 doctors, nurses, and physician assistants. It was taught by an experienced military and civilian trauma center faculty and composed of these particular components: 22 hours of didactics, 4 hours of practical teaching sessions, 5 hours of procedure labs, 5 hours of equipment skill labs, 6 hours with the human patient simulator, and 30 hours of clinical rotations, including on-night call. Methods: we administered a pre- and post-course multiple-choice exam, tested confidence of the attendees before and after the course, tested course satisfaction, and we also performed a post-deployment survey 6 months after the course, after the attendees had returned from their deployment in Afghanistan. We used the Likert scale in our multiple-choice exam to determine the confidence, course satisfaction, and the post-deployment survey. The simulator sessions were done with an ECS Medi with the full TDCK kit, which simulates wounds and bleeding. Each attendee went through 4 sessions. Each time the scenarios were different, but the patients had similar injuries. Organization and ability to do the ABCD protocol from ATLS was scored. Time to perform critical events was also scored, and we compared the first sessions versus the third sessions. This protocol was based on a study published by John Holcomb in the Journal of Trauma in 2002. We used the same trauma team evaluation tool to score organization and performance of A, Bs, and Cs. And we also scored time to afford certain critical maneuvers with the patient. This is a picture from the actual course where an injured patient is being examined by the team. The fourth scenario involved multiple patients, and we did not use that scenario in our study. In this movie taken at the Navy Trauma Training Center at Los Angeles, California, a team taking the simulation session for the first time early in the course is confronted with a multiply injured patient. The team is slow and disorganized. Several minutes into the resuscitation, it still had not obtained definitive control of the airway, has not identified many of the major injuries, and in fact has not yet completely uncovered the patient. A team thrown together for the first time like this has difficulty coping with a multiple trauma patient, regardless of individual skills. This patient requires a chest tube, intubation, and resuscitation, yet things are not happening on time.
Your breath sounds are decreased on the right.
It's okay. It's tangible.
This patient had a chest wall wound, hypotension, decreased breath sounds, but had no interventions for over 3.5 minutes. Later in the same course, at week 3, the same team presented with a similarly injured patient has a different performance.
The full set of vital signs, got pulse about 120, cerebral about 30. He's been talking the whole time, but it really looks like he's starting to have a couple breathing.
This time there is leadership, direction, organization, injuries are identified rapidly, and the appropriate interventions are made in a timely fashion. This is a result of team training, when the team has a chance to practice together as a team with the simulator in a no-risk environment.
running. Everything like going. 2 lines in. 2 lines in.
So there's definitely a difference with team training for trauma teams. 5 courses were taught during the study from January '06 to February of 2007. 75 rotators were trained, and these people were more than 50% of the clinical personnel at Kandahar Airfield in Afghanistan. A knowledge test was done which demonstrated increased knowledge before and after the course. Confidence in 22 different trauma topics was increased, and simulator scores in terms of organization and ability to complete the primary survey were much improved between the first and third scenarios. The time to critical intervention also dropped as the speed of the team increased significantly with training. Rotator feedback, 85% felt that the course and simulator training prepared them for the responsibilities for deployment, and 89% indicated that they had good course satisfaction. This is a team employed in Kandahar dealing with an injured soldier, and once again the teamwork that was learned at the Civilian Trauma Center using the Human Patient Simulator and other types of training pays off. Post-deployment, 20 rotators from the first 2 rotos were surveyed. 75% in retrospect felt that they were prepared. 3 of 3 doctors, 10 of 14 nurses, and 1 of the 3 physician assistants. Of the 25% that did not feel well prepared, those had on average 4 weeks of clinical exposure versus about 18 weeks of clinical exposure for those who were well prepared. This is an issue in military medicine where frequently senior practitioners are not involved in day-to-day clinical care. Did the Trauma Training Center save lives? 90% of returning deployed personnel agreed or strongly agreed with the statement. 19 of 20 felt the Trauma Training Center was very useful. In conclusion, patient simulators improve trauma rotator knowledge, confidence, completion of trauma tasks during resuscitation, and decrease the time to complete critical tasks. Rotators feel the course using simulation is very useful, and those returning from deployment after not feeling prepared may need more clinical exposure, as a 2 to 3 week course may not be enough. If you have any questions or want more information, you can find us on the web at trauma.ucsd.edu. Thank you.